we're going to put together the adjunctive management strategies. Now, we've had trouble with this in the past because there's trials that involve both STEMI and non-STEMI people, and when we tried to divide it up, it didn't work very well. But what Nandan and Wells, who are both our coronary disease experts, have done is they've put together a team approach to talk to you about adjunct and managed strategies. So I'll be very interested to see what you think about this. Before we start, though, let's go ahead with this question. It's a 60-year-old woman presenting with acute onset of chest pain for 45 minutes with this electrocardiogram. So take a minute to look at this electrocardiogram. And the exam is shows a heart rate of 105, blood pressure is down, elevated venous pressure, clear lungs, no murmurs or gallops. Which of the following treatments is a class 3 indication you don't want to do? Okay, hit it. You guys got a little work here. Okay, from the Triton TIMI 38 trial, net clinical benefit analysis, which of the following factors associated with net harm from prasugrel? This is very important. You have to know what patients you don't want to give a certain medication to. So concomitant warfarin therapy, age greater than 65, weight less than 60, prior history of a stroke, TIA, or prior history of GI bleeding. So this is kind of a complicated question. It means that you really know your literature, because there's some that show no benefit, there's some that show benefit, and there's some that show harm. So you have to pick the one that shows harm from prasugrel therapy. All right. Question 3. Rates of stent thrombosis have been shown to be higher with bivalirudin and unfractionated heparin and 2B3As, prasugrel versus clopidogrel, ticagrelor versus clopidogrel, clopidogrel versus abciximab. Rates of stent thrombosis are higher with one of these. All right. Okay, guys. Come on up. Let's see what you can do for us.
All right. Well, Greg gave a very nice overview on STEMI and non-STEMI, and we're going to focus more on the adjunctive medical strategies. So the learning objectives for this first talk, and this will focus on STEMI, is the appropriate type and doses of antiplatelet and anticoagulant therapy during an ACS event. We'll talk about concomitant medical therapy for patients, STEMI patients during an ACS event. And then finally, we'll end up talking about long-term antithrombotic therapy as well as adjunctive therapy after the ACS event. So those are our objectives. Now, to refine those, the goal is really, over the next 45 minutes, to review the adjunctive therapies and the management of STEMI. And we've really focused on the guidelines. Now, based on responses from prior CV board review years, we've tried to avoid a real in-depth review of clinical trials and try to make this really oriented for the board exam. So the reperfusion strategies, Greg talked a little bit about these, and we've divided this talk up into these 3 major subsets, and they parallel what's in the STEMI guidelines. We'll talk about reperfusion at a PCI-capable hospital, reperfusion at a non-PCI-capable hospital, and delayed invasive management and the adjunctive medical therapies with each of these approaches. And again, Greg has gone over the definitions. They're in your handout again in terms of the pharmacoinvasive strategy, rescue PCI, and then one that's still in the guidelines but it's fallen out of favor is the facilitated PCI, and that was the previously used strategy of either full or half dose fibrinolytics with or without a 2B3A inhibitor, and then immediate transfer for PCI within 120 minutes. There hasn't been shown to be any benefit with that approach, and the most recent 2013 STEMI guidelines de-emphasize that. So in terms of the spectrum of acute coronary syndrome, most of these patients arrive with a working diagnosis of chest pain and an acute coronary syndrome, and we're really going to focus on the left-hand side of this graph, and those are patients with persistent ST elevation with a diagnosis of a STEMI. So STEMI is a clinical syndrome defined by characteristic symptoms of myocardial ischemia. In general, they're going to have persistent ST elevation, and that's followed by a release of biomarkers of myocardial necrosis. The cornerstone for STEMI therapy, as Greg alluded to, is reperfusion. Now, reperfusion should be provided to all eligible STEMI patients within symptom onset and preferably within the first 12 hours. That's the Class 1 indication, assuming that it can be performed in a timely fashion, and by experienced operators, we want to go with primary PCI in those patients. So if you look at a flow diagram, patients that present with a STEMI at a PCI-capable hospital, and again, this is just reaffirming what Greg said, the goal is local medical contact to device time of under 90 minutes. Now, if patients present to a non-PCI-capable hospital, and you think that the medical contact to device time can be under 120 minutes, then it's fine to transfer to that PCI-capable hospital. However, if it's estimated to be more than 120 minutes, at that point, the reperfusion strategy changes over to fibrinolysis, and fibrinolytics should then try to be given within 30 minutes after the patient arrives at the hospital. And as Greg mentioned before, if there are contraindications, if it's a high-risk patient, at that point, you can transfer to a PCI-capable hospital. So let's focus on the adjunct medical therapy for those patients presenting to a PCI-capable hospital with the plan of primary or direct PCI. So antiplatelet therapy should be a loading dose of aspirin, 162 to 325 milligrams. Typically, we do 4 chewable baby aspirins, and that should be given before primary PCI. Following PCI, aspirin should be continued indefinitely, and it's reasonable to use a maintenance dose of 81 milligrams of aspirin. In terms of adjunct antiplatelet therapy for your direct PCI, a loading dose of a P2Y12 receptor inhibitor should be given as early as possible or at the time of primary PCI. And in terms of our loading dose choices, it's clopidogrel, 600 milligrams, or prasugrel, 60 milligrams. And a key point here, prasugrel is contraindicated in patients with a history of prior stroke or TIA. We'll go through that later on as well. And then the third option is ticagrelor, 180 milligrams. So those are your loading doses. And then in terms of maintenance therapy, they should be continued for at least 1 year in patients with a STEMI who receive a stent, regardless of whether it's a bare metal stent or a drug-eluting stent as part of this primary PCI approach. Your maintenance therapy doses, clopidogrel 75 milligrams a day, prasugrel 10 milligrams a day, and then ticagrelor 90 milligrams twice a day. And another key point with ticagrelor, remember that the concurrent dose of aspirin should not exceed 100 milligrams when you're using ticagrelor, and that's based off the sub-study analysis from Plato that looked at geographic variations, and patients in North America had less of a benefit with ticagrelor, and it's postulated that perhaps the aspirin dose is responsible for this. So remember, if you're sending them out on ticagrelor, just reinforce that aspirin should be 81 milligrams a day. Now, a few slides just on each of these that may or may not show up on boards. We'll avoid an exhaustive review of each of these. But clopidogrel, remember that the antiplatelet response can vary. And it can vary as a function of the phenotype, so obesity, diabetes. It can also vary as a function of polymorphisms. And the one we most commonly think about is the CYP2C19 polymorphisms, and that can occur in up to 25% of us may have reduced function of one of the alleles. In Triton TIMI 38 and in 3 subsequent cohort studies, patients who were carriers of a reduced function CYP2C19 allele had lower levels of the active metabolite of clopidogrel. There was diminished platelet inhibition in those studies, as well as increased rates of stent thrombosis. Now, other trials have not confirmed these findings. I don't think this is necessarily going to be a testable point, and the guidelines have taken a more moderate approach in terms of genotype testing, saying that genotype testing should only be performed if it's likely to change management. So moving on to prasugrel. Prasugrel has a greater inhibition of platelet aggregation compared to clopidogrel. In Triton TIMI 38, patients with STEMI had a lower 30-day event rate, and that was a composite event rate of cardiac death, myocardial infarct, and stroke, and that benefit persisted for more than 12 months. There was a significant reduction in early stent thrombosis with prasugrel compared to clopidogrel. However, it's important to remember that the loading dose of clopidogrel was only 300 milligrams. The loading dose, as well as the timing of when clopidogrel was administered, may account for some of the differences in efficacy between these two treatment groups. So, to highlight prasugrel for boards, remember that it should not be administered to patients who have a history of stroke or prior TIA. It was not shown to be beneficial in patients over the age of 75 or those weighing less than 60 kilograms. And really, it's maybe best suited for younger patients with diabetes or large areas of myocardium at risk who are at low bleeding risk, and they're able to take dual antiplatelet therapy for the year uninterrupted. Ticagrelor is an oral non-thienopyridine reversible agent. The Plato study looked at ticagrelor versus clopidogrel in over 18,000 patients with acute coronary syndrome. Of those, nearly a third had STEMI. And the bottom line for the primary PCI group is there were significant reductions in both stent thrombosis and total death, favoring ticagrelor over clopidogrel. Now, there were higher rates of non-CABG-related bleeding, and that included intracerebral hemorrhage in the ticagrelor group. This chart's included in your handout. It's taken from the ESC guidelines. It's just a nice quick reference where you can see clopidogrel, prasugrel, and ticagrelor together. It highlights some of the differences between them. The ones that I'll highlight, ticagrelor, remember, it's reversible and it's an active drug. The other two are prodrugs. However, prasugrel is not limited by metabolization. Both prasugrel and ticagrelor have quick onset of action, 30 minutes to reach 50% platelet inhibition, whereas clopidogrel is longer. The duration of effect is shorter for ticagrelor due to its quicker offset of action. And then the other thing to remember is that before major surgery, and ideally, if possible, before CABG, prasugrel should be held for 7 days as opposed to clopidogrel and ticagrelor, which are 5 days. So let's move on to GP2B3A inhibitors. So the evidence supporting the use of glycoprotein 2B3A inhibitors in STEMI really preceded routine oral dual antiplatelet therapy. Subsequent trials after routine oral dual antiplatelet therapy that looked at upstream use of glycoprotein 2B3A inhibitors did not show much benefit. However, it's still reasonable to use these at the time of primary PCI in selected patients who receive heparin. Choices are ipsiximab, high bolus dose tirofiban, or double bolus eptifibatide. And really, the decision to use these to use a GP2B3A inhibitor at the time of PCI needs to be made on an individual basis, and typically it's patients with a large thrombus burden or those who had inadequate P2Y12 loading pre-PCI. So for patients receiving bivalirudin as the primary anticoagulant, routine use of the 2B3A inhibitors is not recommended. The guidelines still say that it can be used as a bailout therapy in select cases. In terms of anticoagulant therapy, the majority of patients receive unfractionated heparin. Additional boluses are given in the cath lab to maintain therapeutic ACT levels, and that's going to depend on whether or not you're using an adjunct intravenous glycoprotein 2B3A inhibitor or not. Alternatively, bivalirudin can be used, and that's regardless of whether there was pre-treatment with unfractionated heparin prior to arrival to the cath lab. In patients with STEMI who are undergoing PCI and those that are at high risk of bleeding, it's reasonable to use bivalirudin in combination with your oral agents as a preference to unfractionated heparin and glycoprotein 2B3A inhibitors. Perhaps it'll provide less bleeding risk. Some of that is going to depend on your radial versus femoral approach, but there is the trade-off of a higher risk of early stent thrombosis with bivalirudin. And the last one to remember, fondaparinux should not be used as a sole anticoagulant to support primary PCI, and that's because of the increased risk of catheter-related thrombosis. So looking at kind of a summary flow diagram, and these are patients who are presenting for primary PCI for STEMI. Your adjunctive antiplatelet agents to support PCI are aspirin. Remember, the loading dose is 162 to 325 milligrams, preferably 4 chewable baby aspirin. You then add on your P2Y12 antagonist, clopidogrel, prasugrel, or ticagrelor. Remember that prasugrel should not be used in patients with prior stroke or TIA. And then if you do use ticagrelor, your maintenance dose of aspirin should be less than 100 milligrams. And then the decision on whether or not to add 2B3A, remember, for the most part, it's going to be patients with a large thrombus burden or who had inadequate oral dual antiplatelet loading. And then on the other side of the diagram is adjunctive anticoagulants. For the most part, it's going to be unfractionated heparin or bivalirudin. Typically, you're going to avoid a glycoprotein 2B3A inhibitor if you use bivalirudin as your primary anticoagulant. And remember, fondaparinux is not recommended as a sole agent. So if we move on from PCI, primary PCI patients to those for fibrinolysis, if you could answer this on your audience response system. What is the correct antiplatelet regimen in STEMI patients at the time of fibrinolysis? Number 1, aspirin and prasugrel. Number 2, aspirin and ticagrelor. 3, aspirin and clopidogrel. Or 4, aspirin and tirofiban. And Greg covered this on the preceding talk.
Okay, good. So excellent. You guys did great on that. So before I go on again, I'd just like to extend my thanks to Drs. Nishimura and Oman for the opportunity to participate. On this part of the talk, I'll be the non-PCI cardiologist, okay? And in this situation, we're really talking about fibrinolytic therapy as a reperfusion strategy. Again, we're going to go in the same sort of systematic approach. We're going to talk about the antithrombotics, then the anticoagulants in this setting, and then some of the nuances. Similar to the direct PCI approach, aspirin is indicated as a class 1 agent, and it's given in the same loading dose and should also be continued indefinitely. Similarly, a maintenance dose of 81 milligrams is reasonable after the loading dose. As you guys have already astutely come to realize, clopidogrel is the only ADP antagonist that can be used in the setting of fibrinolysis. In this setting, there are 2 doses to know. 300 milligram loading dose for patients less than 75 years. If you have older patients, you just give them 75 milligrams. Now remember that all the guidelines come from trials. So the trials are designed in a particular way. And so to the point, the clopidogrel should be continued for at least 14 days, but up to a year. But our guidelines say we want our patients to be on dual antiplatelet therapy for up to a year. And again, as has been already mentioned, the reason why clopidogrel is the only choice is because prasugrel and ticagrelor have not been prospectively analyzed in the setting of fibrinolytic therapy for reperfusion in the setting of STEMI. Anticoagulation is also necessary to support fibrinolysis as a reperfusion strategy. In this setting, it improves vessel patency and prevents reocclusion. After lytic therapy, patients should receive anticoagulation for a minimum of 2 days, and preferably for the duration of hospitalization up to 8 days or until revascularization. These are the preferred agents. It's unfractionated heparin, enoxaparin, and fondaparinux. With unfractionated heparin, you titrate to achieve an APTT of 1.5 to 2 times control, and again, maintain this for 2 days or until revascularization. With enoxaparin, in those patients less than 75 years, you give an initial IV bolus, followed by subcutaneous dose started 15 minutes later. If they're over 75, you do not give that initial IV bolus. You just start with subcutaneous administration. Fondaparinux is administered as initial IV dose, followed by, in 24 hours by daily subcutaneous injections. And a caveat is that it is contraindicated in those with a creatinine clearance less than 30 milliliters per minute. Bivalirudin is not one of the preferred agents, but can be used in this setting, and it's really reserved for those patients who are treated with lytic agents and who develop HIT. So similarly, let's walk through a little flow chart. So STEMI is the ACS. Reperfusion is the cornerstone of our management. And now our patient has arrived to a non-PCI capable hospital. The decision has been made to pursue fibrinolysis. And so we have to pick our agents, our adjunctive antithrombotics, to support fibrinolysis. This includes aspirin. In terms of our ADP antagonist, it's pretty easy. We go with clopidogrel, but we've got to be aware of 2 doses, and those doses are dependent on the age of the patient. A 300 milligram loading dose for those patients younger than 75, or 75 milligrams if they're older. We avoid the GP2B3A receptor antagonists because of the high risk of bleeding. We also need to support fibrinolysis with adjunctive anticoagulants. And remember, the anticoagulants improve vessel patency and prevent reocclusion. The agents include unfractionated heparin, enoxaparin, fondaparinux, and bivalirudin. We're going to now move on to delayed invasive management. Again, Dr. Barsness discussed this. And this really includes those patients who didn't receive lytic agents at a non-PCI hospital because of high-risk features, or they did receive fibrinolysis. And in the latter, those patients could still remain unstable or become stable, but there is an impetus to study their angiographic anatomy. So, cardiac catheterization with an intent of percutaneous intervention should be considered for the following. Those with high-risk features, such as cardiogenic shock or acute severe heart failure that develops after their initial presentation. If they have intermediate to high-risk findings on pre-discharge non-invasive ischemia testing. Again, a point that Dr. Nishimura made during the last session. And finally, myocardial ischemia that is spontaneous or provoked by minimal exertion during that hospitalization. Similarly, intent of PCI is reasonable for patients with evidence of failed reperfusion or reocclusion after lytic therapy. Angiography should be performed as soon as logistically possible. Now, this may come with a higher bleeding risk, but the benefit of reperfusion in this setting outweighs that risk. Angiography is similarly reasonable before hospital discharge in stable patients with STEMI who have been treated with fibrinolytic therapy. And this is that pharmacoinvasive approach. We aim towards getting them to the cath lab within 24 hours. However, we should try to get them after that 3-hour period in order to minimize that bleeding risk. What about the adjunctive antithrombotic agents that we use to support delayed PCI after fibrinolysis? Again, GP2B3A inhibitors have really taken a backseat in contemporary practice because of a very potent antiplatelet agents. And they should be used very cautiously. So the GP2B3A inhibitors should be used very cautiously, if at all, after full dose fibrinolytic therapy. The reason is because the combination is associated with very high rates of bleeding and intracranial hemorrhage. And this is particularly so in our elderly patients. So again, to highlight, the GP2B3A inhibitors have a really limited role to support delayed PCI after fibrinolysis. After PCI, aspirin should be continued indefinitely, and it is reasonable again to maintain that dose at 81 milligrams. Here the guidelines gets a little bit tricky, and it sort of makes a plan B if clopidogrel hasn't been given. So to support PCI after fibrinolysis, clopidogrel should be given as follows. We hope that 300 milligrams loading dose was given at the non-PCI hospital, but if it hadn't been, you can give that 300 milligram loading dose. And if PCI is due to happen within that 24 hours, that 300 milligrams is sufficient. However, we escalate that loading dose to 600 milligrams before or at the time of PCI in those patients who did not receive that previous loading dose and who for some reason are due to undergo PCI greater than 24 hours after receiving fibrinolysis. The maintenance dose of clopidogrel remains the same at 75 milligrams. Again, this is where the guidelines do get a little bit tricky. Now remember, we talked about fibrinolysis as the reperfusion strategy and clopidogrel as the only ADP antagonist that can be used in that setting. But if that patient did not get that clopidogrel dose and they arrive to your PCI-capable hospital, prasugrel then can be used. And it is reasonable, using a 60 milligram loading dose, to administer this medicine once the coronary anatomy is known. Again, in patients who did not receive a previous loading dose of clopidogrel at the time of administration of a lytic agent. So we hope this would be the minority of the case. Some caveats in terms of when you can give the prasugrel, depending on the type of lytic agent. Prasugrel should not be given sooner than 24 hours after the administration of a fibrin-specific agent. And that's the typical agents that we're using these days, the tenecteplase, the TPA. But it should not be given sooner than 48 hours after the administration of non-fibrin-specific agents. Those agents are, for example, the streptokinase or the urokinase, which we're not typically using in contemporary practice. If prasugrel is used, a 10 milligram maintenance dose is continued. And as has been sort of hit home pretty hard, prasugrel should not be given to patients with a history of prior stroke or TIA. In terms of adjunctive anticoagulant therapy, for patients undergoing PCI after receiving lytics and intravenous unfractionated heparin, what we do with the unfractionated heparin is to provide additional boluses as necessary to support the procedure. And the interventional cardiologist really manages that at the time of revascularization. If your patient had received enoxaparin, and if the last subcutaneous dose was administered within the prior 8 hours, you do not have to give any additional enoxaparin. However, if the last subcutaneous dose was given between 8 and 12 hours earlier, you do have to provide an additional dose of enoxaparin at 0.3 milligrams per kilograms IV. As Wells had mentioned, fondaparinux should not be used as a sole anticoagulant to support PCI. And typically you require another agent, such as unfractionated heparin, to support the procedure. Again, because of the risk of catheter-associated thrombosis when fondaparinux is used alone. Let's talk about this in terms of a flow diagram. It might give the more pictorial schema. With STEMI, reperfusion is the cornerstone of management. Our patient has come to a non-PCI capable hospital. For reasons of either failed from fibrinolysis, there's a high-risk patient, continued ischemia, or they're doing well, you can try to, at the same time, organize transfer to a PCI capable hospital for direct PCI. When you plan the direct PCI, you have to support the procedure with adjunctive antithrombotic agents. We want to avoid the GP 2B3A inhibitors. Everyone gets aspirin. Your patient should have gotten clopidogrel. However, in the setting that does not occur, prasugrel now has an option. Remember the contraindication to prasugrel, those patients with stroke and TIA. Our adjunctive anticoagulant therapy in this setting, unfractionated heparin and enoxaparin, and the dosing of enoxaparin really depends on when the last subcutaneous dose was provided. We do not support PCI with fondaparinux in the setting of STEMI. What about patients who are planning to undergo coronary artery bypass graft surgery? Really a limited role in the acute phase of STEMI, other than for shock. Current indications of failed PCI, if the coronary anatomy is not amenable to PCI, or at the time of surgical repair for a mechanical defect. Urgent CABG is a class 1 indication when the coronary anatomy is not amenable to PCI and who have ongoing or recurrent ischemia, they're in shock, or severe heart failure. This will be a short algorithm. Again, reperfusion is what we need to go for, and if we can't do that with lytics or percutaneous intervention, CABG is an option. And in terms of the antiplatelet agents, we continue aspirin, and we have to discontinue the ADP antagonists. And this can present a problem to our surgeons if they've already received this. We're now going to switch gears a little bit and talk about the other medical therapies that help in terms of the outcomes of our patients who present with STEMI. Oral beta blockers are one of those agents that have proved to be quite efficacious. And in fact, they should be initiated within the first 24 hours in patients with STEMI who do not have any signs of heart failure or low output state, or who are otherwise not at an increased risk for cardiogenic shock. So you want to avoid beta blockers in those individuals. The one other indication where you want to avoid beta blockers is when there is an underlying conduction system abnormality. If there's an absence of these risk factors, you want to try to initiate oral beta blockers within the first day. You want to continue the beta blockers in patients once it's initiated and up-titrated. Now, a patient that arrives to you may have a contraindication to beta blockers on day 1, but this should be reevaluated on a day-by-day basis to determine their subsequent eligibility. Inhibitors of the renin-angiotensin-aldosterone system have also been efficacious in terms of outcomes, and an oral ACE inhibitor, they have been found to reduce fatal and non-fatal major cardiovascular events. The protective effects have been well established in clinical trials, and as to be expected, the magnitude of their clinical benefit is really greatest in the highest risk patients. And so what are these patients? Those presenting with an anterior MI, pump dysfunction, and heart failure. Others who benefit are those with prior MI and tachycardia. But the first three in particular, if this is present, you should really be trying to initiate an ACE inhibitor within the first 24 hours. If your patient has a contraindication to an ACE inhibitor, an ARB should be provided. Aldosterone antagonists, also part of the affecting the renin-angiotensin-aldosterone system, should be given to patients with STEMI and no contraindications who are already receiving an ACE inhibitor and beta blocker with pump dysfunction and either symptomatic heart failure or diabetes. So again, these patients should already be on an ACE inhibitor and beta blocker, but in addition to the measured pump dysfunction by left ventricular ejection fraction, there should be either symptomatic heart failure and diabetes mellitus present as well. The Ephesus study really established the benefits of eplerenone in this setting, and when added to optimal medical therapy between 3 and 14 days after STEMI in eligible patients, and those included as long as the renal function was less than 2.5 milligrams per deciliter in men and 2 in women, as long as the potassium was less than 5, and the EF was less than 40%, with those caveats of symptomatic heart failure and diabetes mellitus, there was benefit. The benefit was actually seen when the drug was initiated earlier. And the benefit was with regard to all-cause mortality, sudden death, and cardiovascular mortality and hospitalization. Notably, if the drug was initiated late, we didn't see these benefits pan out. This can be a problem because titrating multiple drugs in these patients, it takes time, but it's important to be aware of their efficacy. Lipid management, treatment with statins and STEMI, again, lowers the risk of coronary heart disease, recurrent MI, stroke, and the need for coronary revascularization. And this should be initiated in all patients presenting with STEMI unless there's a contraindication. Long-term anticoagulation can be tricky, and it should be really in those patients with STEMI who have a need for ongoing anticoagulation, i.e. atrial fibrillation, mechanical valves, a history of venous thromboembolism, or a hypercoagulable disorder. Triple therapy is especially anxiety-provoking, and this is defined by the use of a vitamin K antagonist, aspirin, and the P2Y12 inhibitor. It's restricted to specific clinical situations where you have to weigh the balance between the risk of systemic or venous thromboembolism versus stent thrombosis, okay? And that risk has to be weighed against that of the bleeding with having those three medicines on board. If triple therapy is used, its duration should be minimized to the extent to limit the risk of bleeding. Similarly, if triple therapy is mandated, at the time of PCI, you want to use a strategy that may limit the need for dual antiplatelet therapy, so avoidance of drug-eluting stent is preferred in that situation. A note about the novel oral anticoagulants. An in-depth discussion is beyond the scope of this talk, but just to review, bleeding rates are increased relative to dual antiplatelet therapy when added. Absolute bleeding rates, however, are modest relative to warfarin plus dual antiplatelet therapy. Caution is advised to their use, but we need more investigations for definitive recommendations. In terms of sugar control, Dr. Rihal had mentioned up to 1/3 of our patients have diabetes, and there's a U-shaped relationship between glucose levels and death in acute coronary syndrome. The NICE sugar study really looked at medical and surgical ICU patients, and tight glucose control versus modest glucose control was associated with increased mortality rate, primarily from cardiovascular causes. And there were also increased episodes of symptomatic hypoglycemia. Miscellaneous medical medicines include nitrates, calcium channel blockers, oxygen morphine, and we'll be talking a little bit more about that in the next chapter. Lifestyle changes. You can't give medicines without provoking a discussion about lifestyle changes. If your patient is smoking, you have to encourage them to stop. Smoking cessation reduces the subsequent cardiovascular mortality by nearly 50%. Cardiac rehabilitation is also integral. They have to be enrolled. It increases functional capacity, decreases anginal symptoms, reduces disability, improves quality of life, and modifies the coronary risk factors. So looking at the routine medical therapy, we've reperfused our patient. We have to add medicines that modify the disease. These include beta blockers, renin-angiotensin-aldosterone system inhibitors, and statins. Anticoagulation needs to be considered in those patients who have atrial fibrillation, mechanical valves, venous thromboembolism, or hypercoagulable states. Miscellaneous agents include nitrates for ischemia, calcium channel blockers if there's a contraindication to beta blockers, and we'll talk more about that in the next session. Oxygen and morphine. A note that glucocorticoids and NSAIDs, apart from aspirin, are contraindicated in ACS. And lifestyle changes, including cardiac rehabilitation and smoking cessation. Just to recap what we've talked about, STEMI for reperfusion strategies. If they come to a PCI-capable hospital, you go with PCI. And our system goal is to have a local medical contacted device time less than 90 minutes. If they come to a non-PCI hospital and that medical contact time to device time is less than 2 hours, arrange a transfer to PCI-capable hospital. If not, we have to determine whether they are a candidate for lytic agents. If they are, we want to give that within 30 minutes. If they're not, we transfer them to a PCI-capable hospital. If PCI is the reperfusion strategy, we have to support that with antiplatelet agents. This includes aspirin, a P2Y12 inhibitor, and that includes either clopidogrel, prasugrel, or ticagrelor. GP2B3A inhibitors have a limited role, but in this setting can be used if there's a large thrombus burden or inadequate loading of that P2Y12 inhibitor. Your adjunctive anticoagulants include unfractionated heparin, bivalirudin, and the bivalirudin should be avoided in patients who are, GP2B3A inhibitors should be avoided in patients receiving bivalirudin. And finally, fondaparinux should not be given to these patients. If your patient arrives to a non-PCI capable hospital, again, the supporting antithrombotic agents include aspirin and clopidogrel. There's no role for prasugrel or ticagrelor. And again, you want to avoid the GP2B3A inhibitors because of the high bleeding risk. Your adjunctive anticoagulants include unfractionated heparin, enoxaparin, and fondaparinux. Bivalirudin is an option in those who have a history of HIT. Finally, the pharmacoinvasive approach. We want to get our patients, even if they've arrived to a non-PCI hospital and if they've received fibrinolytic agents, we want them to get to a PCI-capable hospital. And at that time, hopefully the medicine should be straightforward, but you still do have options. If they have received lytics, avoid the GP2B3 inhibitors, continue aspirin, continue clopidogrel. If they did not receive clopidogrel, there is an option for you, an option to use prasugrel. Your adjunctive anticoagulants, continue unfractionated heparin. If they received enoxaparin, you can continue dosing, and that dosing depends on when their last subcutaneous dose was given. And again, do not give fondaparinux. And this will go through rather quickly the routine medical therapies. These include the disease-modifying drugs. Think about the patients who require anticoagulation. You want to minimize triple therapy. You have miscellaneous agents, and we'll go into more detail in the next session. And never forget lifestyle changes. That's integral to their care. These are the clinical guidelines which are in your syllabus.
All right. So I hope you've noticed that this is one of the few talks you've seen on adjunctive therapy that they're not showing graph after graph after graph after graph. And that was a specific decision on their part because you get bored with all of these graphs, and what you really want to know is, do you use the drug or not use the drug? So you'll have to tell us what you think about this in your evaluation, but I really like that approach where they're just giving you the bottom line and not the 29 different trials that show a statistically significant difference between one thing or another. So let's go ahead and back to the questions, and we'll have, Wells, I'll give you this so that you can stay at the microphone. Okay. Come on up. Okay, so we've got a 60-year-old woman who has the acute onset of chest pain for 45 minutes with the following ECG findings. Now, before I let you guys off the hook, that heart rate looks irregular, doesn't it?
Yes.
Why? And is that going to do anything for us? So what is that? What is that rhythm there? Either of you guys.
Yeah. So there's a conduction abnormality going on here.
Mm-hmm.
So looks like it's an inferior MI.
Yep.
That we're worried about. The conduction abnormality is probably an RCA lesion, probably proximal. And that's one of the issues we've got to be worried about in this presentation for an RV infarct. Well, we'd be worried about an RV infarct with probably a very proximal right coronary artery occlusion, and it's a conduction block that we're seeing here.
Conduction block at the level of the AV node.
Yes.
Okay, so I think that when we look at the electrocardiograms, we not only look for those ST segments, but this this conduction block at the level of the AV node, and it's probably AV node because it's inferior, is going to make a difference that Jeff's going to be talking about when we start talking about heart block, but it also is going to affect adjunctive therapy. So I didn't want the audience to just kind of look at this and say it's only inferior and go away, but we have to always look at the rhythm that Nandan is talking about. Okay, let's go to the next slide then. So the heart rate's 105, blood pressure's 95, elevated venous pressure, clear lungs, no murmur or gallop. Which of the following treatments is a class 3 indication here? IV fluids, dobutamine, nitroglycerin, or dopamine?
Good.
Okay, good.
Yep.
And why?
So, sort of gave it away when we discussed the ECG. The findings in this patient probably is probably inferior infarction. And then when you look at the vital signs, you see a heart rate is tachycardic, blood pressure's on the low side, JVP is elevated, and the elevated JVP in the setting of clear lungs, you got to be concerned about a right-sided issue, an RV infarction. And in the RV infarction, what you want to do is you don't want to get rid of that preload. So of these, the first mode of treatment would be to provide fluids. You continue to provide fluids as they tolerate it, and it has to go by the physical exam as well, because if you provide too much fluid, you can actually paradoxically make things worse by creating a pericardial constraint. So despite intravenous fluids, if that doesn't work on its own, you can use presses. And those include dobutamine or dopamine. But nitroglycerin won't help in this regard, because remember, nitroglycerin will take that preload away, and that can make that situation worse in this setting. So the teaching point here is in the right ventricular infarction, you want to be, with the clinical exam, when there's a clear lung field and elevated JVP, inferior MI, think about RV infarct, and the supportive care for RV infarct will be fluids, and then inotropes if necessary on top of that.
Okay, but what about inotropes in the setting of a STS segment elevation with a heart rate of 105? Can you or Wells comment on that? What you would clinically do in this situation?
So with the heart rate 105 and still hypotensive, and if we've given a good challenge of fluids, the heart rate will go up with dobutamine and dopamine. I would still try it. Would you use something different? Or?
We just make sure we had revascularized the patient.
Yeah. I think what that's telling you is you got to get the patient revascularized as fast as possible. And to try to give an inotrope at a heart rate of 105, I think might be, you got to be very, very careful about that. So in addition to all this fancy stuff with all the medications, you still have to go back to your old double product, which will increase the myocardial oxygen demand. And you should be aware of these patients who come in with heart rates of over 100. You probably don't want to give them anything that's going to make their heart rate worse. And like Wells said, get to the meat of the things as soon as possible in that patient. Okay, question number 2. From the Triton-TIMI 38 trial, net clinical benefit analysis, which of the following is associated with net harm from prasugrel therapy? So this is a good question, because when you read the labeling, you have some of these, quote, contraindications, but some of them are net benefit, some of them are no benefit, and some of them are harm. Good. You can give yourself a round of applause to that. Now, there's a question on prasugrel, though, because you said that you don't want to give it upstream, right? What? Go ahead.
Yeah, I mean, I don't know what part we had said that, but in terms of prasugrel for STEMI, it's fine to give it upstream. It was done in a certain percentage of the patients for Triton-TIMI 38. I don't remember the exact percentage, which got it upstream versus at the time of PCI, so the coronary anatomy had already been defined. When we talk about non-STEMI later, we'll typically avoid upstream utilization of prasugrel.
Okay, but also the patient who has the thrombolytic therapy and then comes to the cath lab at another institution, you don't want to give prasugrel upstream.
Not upstream.
And so go ahead and talk about that.
Right. So at the other institution, if they've not received clopidogrel and they've come to you, again, the choices are to give clopidogrel, or at the time of PCI, that's after the coronary anatomy has been delineated, then the option of prasugrel comes into play, and you'd load them with the 60 milligrams.
But that's one, like you're going to talk about with the non-STEMI,
Yes.
that you don't want to give prasugrel until you've seen the coronary
Yes.
anatomy.
Yes.
And then so the primary PCI, and we'll go back into the antiplatelet agents. You can give ticagrelor, you can give prasugrel, you can give clopidogrel. But when you talk to patients, they don't want to pay that much, or they don't want to take a BID dose, and you might want to then switch them to clopidogrel after they've been on ticagrelor. Can you talk to us about how you do that and why and things?
So I think oh, go ahead.
Yeah. In general, what we'll do a lot of times, our practice has been we've shifted more to ticagrelor for a lot of our STEMI patients that come in for primary PCI. And for whatever reason, if we're concerned that they won't be compliant with twice daily dosing, or there are financial concerns, we'll switch them from ticagrelor to clopidogrel. And what we do is, at their next scheduled dose of ticagrelor, you withhold the ticagrelor, and then we reload with 600 milligrams of clopidogrel.
At the time that they were supposed to be
At the time they
taking.
were supposed to receive their next dose of ticagrelor.
Yeah. And you'll find, I mean, I'm sure you've all experienced this, but even though ticagrelor is supposed to be better, it's more costly, and patients don't like taking a BID dose. And I think the majority of our patients actually end up saying, just give me that 75 milligrams of clopidogrel, and then we have to do what Wells said in order to switch them over. So ticagrelor has definitely been shown to be a better drug, but from the practical standpoint, I think the majority of our patients kind of go back to clopidogrel long term. One comment, and I don't know if you're going to comment about the non-STEMI, but what about the recent data about continuing lower dose ticagrelor a year after your STEMI or non-STEMI? Any thoughts? Now, this certainly isn't going to be on boards, but we've heard about it. What are your thoughts about the possibility of doing that at a later time?
Yeah, I mean, I think a lot of it comes from the patient's coronary anatomy and then their bleeding risk. And that's typically what I tend to use, and when I'm seeing these patients a year afterwards, that if I want to extend their dual antiplatelet therapy, that perhaps there is benefit from continuation of prolonged dual antiplatelet therapy with the recent DAP trial. Some of that is going to be due to de novo coronary lesions, or rather than necessarily the affected lesion that was stented before. But for the most part, I've still done just a very individualized approach.
And weighing the risk, yeah, pretty much. Good stuff. Okay, let's go to question 3. The rate of stent thrombosis is shown to be higher with bivalrudin versus unfractionated heparin and 2B3 inhibitors, prasugrel versus clopidogrel, ticagrelor versus clopidogrel, or clopidogrel versus abciximab. Very good. One last, were you going to say something?
No.
One last thing for adjunctive medical therapy. You might run into a person who comes in with a cocaine-induced myocardial infarction. Is there anything you might do differently with the cocaine-induced myocardial infarction that you're not going to do with a routine one?
Yeah, I mean, in general, in terms of the adjunct pharmacologic agents, we're going to avoid our beta blockers up front, and that's the big medical therapy difference.
Yeah, it's something that people like to throw out, because you'll occasionally get a cocaine person taking cocaine comes in with a big infarct, and you just don't want to give that person a beta blocker because of what may happen.